Hello and welcome. As we speak, in cities like Mumbai, the number of cases of coronavirus are surging. In zones like Dharavi within Mumbai, the count is higher than entire states like Bihar and Karnataka. And we are now gearing up for the beginning of the end of the lockdown. So what's going to happen then? Well, beyond a point, we don't know because it's a Hobson's choice. Will the hospitals and the healthcare system manage to manage the caseload that will definitely increase as it looks like? How will they grapple with the continued load of COVID cases as well as non-COVID cases, which are also now likely to surge? Well, let's talk about whether there could be another approach, a different approach, which needs to be now embedded into our thinking, consciousness, and working as we go ahead. To discuss this, I'm joined by Nachiket Mor, until recently country director of the Bill and Melinda Gates Foundation, earlier on the boards of the Reserve Bank, CRISIL, and he was formerly also the deputy managing director of ICICI Bank. Nachiket, thank you very much for joining us. So, Nachiket, tell us, you are working on a concept called the empowered communities concept, which you believe is the only way to gear ourselves and not to depend on the hospital or the public health system.
So, clearly, it depends a little bit on what we think is going to be the trajectory of the disease that we are concerned about, and what is the health system that we would like to build as we go forward. So these are kind of twin goals that we have to keep in mind. There is one point of view which suggests that maybe India is different, things will even out more quickly, the rates we are seeing are more modest. That may well be right, and I really hope and pray that that is right. Whatever I understand, though, there's nothing about the virus that we are seeing that seems to suggest that Asians, Indians, or hot temperatures are in any way doing anything specific, to halt the spread of this virus. My understanding also of this idea of flattening the curve is that it doesn't actually change the area under the curve. It allows us more time to respond, but it's entirely possible that the virus will continue its onward march and will give us the kinds of numbers that we have been, told about at the beginning of the pandemic. There's some evidence from elsewhere in the world as well that when they tested for antibodies, even in those countries where, or those regions where you didn't see as many cases, you actually saw a reasonably large number of people that had been infected but did not actually know. And in any case, even if we actually have the experience at the end of the day, 2 years later, that the numbers were modest and that, we didn't have been as worried, I would argue better to over-prepare and somewhat find yourself embarrassed that you're over-prepared than be under-prepared and then find that you are losing lives or you are not able to cope because now your systems have got flooded. Particularly if that response also helps to prepare a health system for a longer term future, which is separate from COVID or issues other than COVID, even in the current process, I would say there is a real case to be made. There's also another word of caution that propels me to think in this way. If I look at the experience of the European countries, particularly Spaniards, Italians, and the Italians have written about this quite a bit, is that as the caseload went from 10 per 100,000, which is where roughly India is, to 300 per 100,000, and I think Bombay has already crossed 50 per 100,000 in terms of cases. Even a well-prepared health system like Lombardy in Italy got overwhelmed. Not only did it get overwhelmed, the hospitals became the place from which infection started to spread. It became the hotspot rather than being the place where you're getting containment. So, again, we have that evidence, therefore we can prepare better, we can be, in better shape. So I'm not saying, therefore, those lessons have to be repeated here. But there is a word of caution that also gives. And they, in the very passionate editorial, doctors from Lombardy write that they had not realized that this approach of treating every patient as an individual patient, not recognizing that this is a patient from a community, from a pandemic, was an error. Health workers started to get sick, transportation workers started to get sick, ambulance workers started to get sick, because you were following a model that was an appropriate model if there was just one patient with one disease, not recognizing this is a larger problem. The direction that I feel there is a value to do what I'm calling more a complementary approach to what the current approach is. The current approach is very much hospitals, ventilators, central quarantining, try to build social distancing through lockdowns and such like, to something that perhaps can survive us and last for a longer time, which is to start engaging the community much more actively right away. Because communities are not homogeneous entities. You have to work with them, you have to stay with them, and start to do two levels of things. One is make sure that the message that you're communicating is really being heard by everybody. Even today, surveys are showing that while we in the cities with the flood of television and flood of news are perhaps well aware of what's going on, as you go further and further away from the so-called center, you start to see a dissipation of knowledge and information. Particularly, this disease has one particular characteristic that I think it's very important to be extremely conscious of, is that while anybody can get infected, the mortality profile changes quite steeply once one crosses the age of 60. And if indeed the view is, and that's certainly the view I'm hearing, is that there is no cure, there's no real possibility of keeping the virus out, even of very strongly controlled environments like South Korea, Japan, Germany. We have to find a way that people who are above the age of 60 are protected. And rather than a diffuse message to say, everybody be protected, everybody must wear masks, everybody must wash hands, I think a much sharper message that 60-year-olds and above need protection much more carefully. And they may need to be prepared for a longer term engagement.
Right, and I'm going to ask you about how you are seeing this unpack. Now, tell us about that number per 100,000. So you are saying that 10 to 20 is manageable with our existing health systems or public health systems, including hospitals and nursing homes. But the moment you touch 50, in any place, you are really beginning to lose control. And that's happening in cities like Mumbai.
50 is what I'm seeing from the Bombay experience. There is some anxiety that Bombay is running out of capacity at 50. Lombardy ran out of capacity at 300 per 100,000. So, it's still a little bit of a distance, depending on what you count as your doubling rate, etc. We could get to 300, in not too distant a future in Bombay.
And this is 300 intensive cases, as in we are not saying that anyone who is infected, because I guess,
this is just benchmarked against total infection rate, not severe cases. It's just a benchmarking mechanism, because the belief is if you have 100 cases, 80 will get okay on their own without too much effort. 20 will need attention. And then I want to talk to you a little bit about how that 20 is distributed so that we are clear what we can do with the 20 and how can we get some improvement there.
Right, and you mentioned hospitals and ventilators, and you also talk about oxygen in your paper. Now you also argue that basically that's not what we should be doing, which is buying expensive ventilators or investing in too many intensive care units, or even if we do that, that's not going to solve our problem.
Yeah, the suggestion I'm making is we should do that as much as we can. I'm not saying therefore that's a bad idea, but whatever evidence that we are seeing is the following. Out of the 20 people that are needing severe attention. Now, of course, this data may change as we learn more about the Indian information, but from what we know today, almost 15 to 16 people, 75 to 80% of that 20 are going to be needing oxygen capability, not ventilator capability. And that capability of oxygen can be provided in non-ICU, non-critical care settings, not necessarily needing all of the paraphernalia of a ventilator structure. Now, the 4 or 5 that do need a ventilator, unfortunately, whatever again evidence we have so far, again new data could change that. is that a very high proportion of those, somewhere between 80 to 95%, don't make it.
Yeah.
Right? So really, the question that you have to ask yourself is that if you are planning an overall exercise of where to invest resources, certainly the ventilators are going to be important for a portion of the people. But investing in creating a far wider and much cheaper oxygen capability. Now, I understand from the people that need oxygen, a reasonable proportion, maybe about half, need simple oxygen capability. They don't even need complex machines. Simple cylinder, put a valve, and give people a modest amount of oxygen. There will be a group that will need more oxygen, more attention. But again, while I'm not saying I can do it in a street corner, you don't need the kind of heavy infrastructure. More importantly, you can do it closer to where the patient is, rather than transporting him or her to locations where on the way they have the risk of infecting a number of people and exhausting the resources of hospitals that are needed for intensive care cases. And we should not forget all the other cases which are non-COVID related that will also need hospital care.
Right, and that's something that other epidemiologists have been pointing out, that what's going to happen as we start lifting the lockdown, because we will see a surge, and then there's in the western part of the country and cities like Mumbai, you will have the monsoons coming, and that brings its own set of diseases. So tell us about empowered communities. How How will an empowered community work, and how are you visualizing this?
So, for example, I'll give you a concrete example. I've been in dialogue with the Ambuja Cement Foundation. They have a fairly big reach. They are a mature NGO working for years in the various catchments that they are working, a fairly large catchment population. In my view, what they have done is almost textbook. They've gone out there and made sure they have fully counted everybody that works in there or that lives and works in the catchment areas that they work. They have identified the high-risk candidates with comorbidities, with old age, etc., and targeted them for special attention, special phone calls, making sure that they are okay, making sure that the families are aware what the issues are. They're well supplied with protective gear so that they can make sure that the senior citizens are well taken care of. Then what they have done is gone out there and thought about, in case the crisis gets out of hand, what are the local resources that are available? Are there isolation capabilities available? I was talking to actually somebody else in Odisha in the tribal belt, another primary care provider. She is working, to make sure that there is an isolation hut in every village. That's something that the empowered community can do. In crowded areas, there's another group that is working to figure out how do you do in Bombay slums or in villages which are densely populated. There are some choices, right? This disease does not transmit through the air. It transmits through droplets, right? It does not transmit through mosquitoes. It transmits through droplets, right? What you can do is build collaborative arrangements. 4 families get together, and one of the homes, one of the rooms, one of the kholis is identified as the isolation kholi, and the other members are accommodated in the rest of the family. Because this disease has a unique characteristic which is different from others that allows, if you have a simple wall, you can manage. Some places they have said sleep on the, we have the tradition in many parts of India in the summers, you sleep outside on the roof, right? See if you can use that as a way to manage your isolation. Another very important step that they're taking is to identify the healthcare providers in the vicinity and trying to understand what is the preparedness of each healthcare provider. What is the phone number? Does he have a mobile number? What is the setup of the clinic? Does he know how to manage? Because there are all kinds of protocols. A patient comes in, I don't know if he's a COVID patient or not. He's coughing. He's maybe not even coughing, right? He's just shown up with fever. How do I organize my clinic so that there is a febrile section, there is a upper respiratory tract infection section, there is a, how do you manage the queues, open air, outdoor? And then a conversation about what would these primary care providers like to do as they move forward, right? Particularly smaller clinics, nursing homes, maternity homes. Would they be interested in upgrading their capabilities to add on some oxygen capacity? Simple oxygen capacity, with cylinders and such like, adding an oxygenator. Is that going to make sense? There is an organization called Basic Healthcare Services in rural Udaipur. Right? They've gone ahead and kitted out their clinic with oxygen capability. Because again, they don't know the person has COVID or not. They are seeing somebody getting hypoxic. They can start to respond fairly quickly. Right? Some people might be willing, and these are particularly many hospitals, maternity homes, to say, I want to go one step further. I want to build and install a 95,000 rupee machine, which is called the high flow nasal cannula machine with a helmet to prevent transmission of the disease, so that I can actually take care of maybe a slightly higher level. Now that will of course need permissions from the government and all of that. But again, this is a useful kind of investment to make for the future of primary care and of healthcare systems. So in my mind, that is what an empowered community approach would look like, in which now community after community, you're identifying either community leaders or community-based organizations to say, can you follow this checklist of 4 or 5 things that you do in your neighborhood and really take charge of the people that are working with you? Because this crisis is not going away soon. It may be 12 to 18 months even when you are still grappling with it. You will have to return to normalcy, but there will be things that you will have to do differently. Now, instead of waiting for instructions from elsewhere, can you do something more yourself?
Right, and you also feel that, and you touched upon it, that this can be replicated in highly congested cities like Mumbai, where you have, let's say, a population of 20 million and maybe apartment complexes which have anywhere between 200 to 400 families.
Yeah, I mean, clearly there are limitations. I'm not saying everything can be done, but finding ways in which you're bringing care closer, building isolation capabilities closer, trusting communities to work. This is what the Italian experience was. Do not, the doctor says in so many words, do not transport these people. Treat them in place. Make sure that you can, they stay there. You bring treatment to them rather than shift them here and there, because we don't have capacity in the central place. The central place is becoming a source of infection. And people feel more comfortable if they are with people they recognize, they understand. The disease is going to spread anyway. No matter what you do, it's going to, the sense that we have that somehow we can contain it is not consistent with the nature of a respiratory virus, right? And the kind of social distancing that is feasible for a country like ours, which means we have to be mentally prepared that the infection will be there. What we have to decide is, what do we want to do about people that need attention? The empowered community approach is try to do this in collaboration with the community, not in conflict with them, not by forcing action on them that they're not comfortable with, but something that they feel much more satisfied.
Right, and last question, Nachiket. So, to people who are watching this and will watch this, what can I do? And how can I contribute to this creation of an empowered committee, empowered community, or the formation of an empowered community?
I mean, my understanding is that the community is an amorphous idea, and somehow in our mind we think lakhs and lakhs of people. Your own housing colony. Can you sit down in your housing colony and take simple steps about what to do with senior citizens? What is our plan, right? What is my action plan when tomorrow something goes wrong? Do I know where to go? What if the hospital that I'm supposed to be sent to doesn't have capacity? What is my plan to do that? Do I know a local primary care provider? Do I know a local facility that can actually do this, can help me out, right? Am I well equipped to understand all the pieces that are necessary? Some of it is happening already organically, but a lot of it is, in some ways, I get a central direction to my home on my TV, I follow that, rather than sitting down together. Now, of course, housing societies are doing it, but somehow the evidence seems to be more about, I will prevent you from coming in, I will prevent you from going out, etc., rather than, can I sit down together and see what is my action plan as things move forward and situation requires attention and support from my neighbors, support from my community.
Right, Nachiket, thank you very much for speaking with us. We're going to tag those papers that you've written, including the guides for primary care providers and non-profits, and hopefully we'll get a lot of feedback and this becomes an integral part of the fight back against coronavirus. Thank you very much for joining us.
Thank you very much for having me.